So this is lesson 4 of a 9-part series, I think. I should know, but this is lesson 4 on uveitis and systemic disease, okay, which are usually 2 separate entities together, but we've tried to condense them into one presentation, okay? So if there's anything that's missed, obviously try and explore it in your reading outside, but we'll try and cover everything that's kind of hot topic for the Duke Elder. And I think usually uveitis is quite a poorly understood condition, whereas the other stuff that we get taught in med school, theoretically, like diabetic retinopathy and hypertensive retinopathy, we usually get flogged to death with. So hopefully that's a bit easier reading compared to uveitis and stuff, okay? So as always, small disclaimer, this is kind of a revision series, hopefully, for you guys. We're trying to explore more concepts that hopefully you've heard about more than anything. Obviously, we're a bunch of doctors ourselves, and we're quite junior in our training. So if there's anything that doesn't seem right or seems a bit fishy with what we're telling you, do correct us or ask the questions, you know, and challenge us, because we'd like to know ourselves. And sometimes we might make the occasional mistake with the facts that we say. So don't feel threatened to, you know, challenge us or anything like that. There's myself, Tom, and Razor. There's 3 of us who are trying to organize this series and teach on a regular weekly basis. We all love medical education, and we have a website at www.slamdunkelder that kind of encompasses all our resources as well as previous lectures. So go have a look when you have the time. And hopefully the goal of this course is to get you all to pass the Duke Elder, which isn't usually quite hard. It's usually getting in the top 10 to 20% that usually people find difficult. And if you're really good, that's where you get. But, you know, passing to get a point or to learn about ophthalmology is not that hard. So the learning outcomes for this lecture on uveitis and systemic disease. So we'll talk about the different types of uveitis and how it's classified. Okay, we'll talk about the pathological classification, the anatomical classification, and how each one's different to the other. We need to appreciate that uveitis is usually top of our differential for the cause of a red eye, but always kind of appreciate the clinical presentation in terms of our history, as well as examination in terms of where we rank uveitis as a differential, okay? We need to describe the classical signs of an inflammatory eye disease, or classically in uveitis, because there's a lot of kind of eponymous terms as well as classical signs that we see in uveitis, okay, that carry very confusing names that we use to confuse our patients, okay? We need to appreciate systemic disease that can sometimes manifest in the eye. Sometimes this might be actually the first presentation of systemic disease, for example, diabetic retinopathy. People might not know that they have symptoms of diabetes until they start to lose or have trouble in their vision. So a lot of systemic conditions might manifest in the eye at first in terms of their presentation. So we'll cover stuff endocrine, vascular, rheumatological, as well as a bit of dermatology, a teeny weeny bit of dermatology, because I hate it. And then we need to understand that systemic disease affects the eye. And as always, I like to direct your attention to the Royal College of Ophthalmologists, because they have a brilliant curriculum as well as learning outcomes for ophthalmology kind of knowledge at a student as well as a foundation level doctor stage, okay? So always go back there for reference if your med school doesn't have any learning outcomes. And even though it seems overwhelming, you only need to know basic principles, okay, at the medical school level. But to pass the Duke Elder, you do need to go in a bit more depth, okay? And read stuff like the ABC of Eyes textbook, just that kind of level of knowledge, okay? But hopefully everything we'll cover in our series. We've done the pre-quiz, so if you haven't finished that, wrap it up. Also, Razor and Tom are here today. So if you have any questions, they'll do their best at answering them, okay? Because I can't really see the chat and multitask, unfortunately. So let's start with our first learning outcome, which is appreciate the different types of uveitis. If you guys were here for our anatomy lesson, here's a quick recap, okay? So there are effectively 3 different distinct layers to the eye in terms of anatomical division, okay? We have effectively the outer layer, okay, which involves the sclera as well as the cornea. We have the middle layer, which is the vascular tunic, okay? The outer layer is known as the fibrous tunic. It's primarily there for protection and keeping the integrity of the eye like a bowl, essentially like an oval. And then we have the middle layer, which is the vascular tunic, okay, which composed of the choroid in red, the ciliary body, as well as the iris. And this is stereotypically the very vascular structure. It's rich in vessels that supply the neurosensory layer, which is here, our final inner layer, okay, that composes of primarily the retina as well as the optic nerve, okay? So the middle layer has the vascular structure, the outer layer is the protection, and the inner layer is effectively the thing that lets us visualize and interpret the world around us, okay? So that's how the eye is roughly organized in terms of anatomy, okay? And whenever we're talking about uveitis, okay, quite a fancy-pantsy term, effectively what we're thinking about is anything that's going to be affecting the middle layer, okay, which is the iris, okay, so for example, iritis, the ciliary bodies, which is cyclitis, okay, so stuff like iridocyclitis can sometimes be a term used to describe an inflammation that's occurring in the iris as well as the ciliary body. And then we have the choroid, or chorioretinitis, okay, or choroiditis, okay. Very rarely do these conditions exist on their own, okay, so it's very rare to see a kind of independent cyclitis without having some form of pathology elsewhere. So I think it's more of a theoretical concept rather than necessarily the best way to describe certain conditions. So we'll talk about the clinical classification. But for all intensive purposes, uveitis is inflammation of the uveal tract, or the middle layer of the eye. I went to Southampton Medical School and we used a fancy term, well, not so fancy, but DAPSI-camp to approach all our conditions. And that's what I'll try and do with uveitis. And what DAPSI-camp stands for is just essentially another mnemonic, which says define the condition, describe the etiology of the condition, talk about the pathophysiology of the condition, the signs and symptoms, the investigations you might do, the complications, the associated syndromes or conditions that come with that initial disease, the management, and the prognosis. So unfortunately, that's just how my head works these days. So that's what I'm going to try and do with uveitis. And we're infamously famous, if you ever visit Southampton, for the Jesters Club. So if you ever want to visit Jesters for a night out after some solid revision, that's where you go, okay? So that's Southampton royalty right there. Okay. So uveitis, we talked about it being an inflammation of the middle layer of the eye, and it's also from an embryological perspective termed the uveal tract. So that includes the iris, okay, the ciliary bodies, which is cyclitis, and the choroid. For all intents and purposes, that's the anatomical definition of the uveal tract. And the uveal tract stems back from a Latin term, okay, we've got some gluttonous Latins here, okay, or Romans, in fact, who fed off grapes. And whenever you transect a grape, the first anatomists, who kind of probably stem back to like early Italy formation, they saw that the grape resembled almost like an eviscerated eye. So they used to eviscerate the eye, plastinate the eye, and then cut it in half. And they said it looks similar to the layers of a grape. I mean, I personally can't see that myself, but that's where the uveal tract comes from. It's basically Latin, uva, for grape. So how do we define uveitis? There's a few classifications that we use for uveitis, unfortunately, and they all kind of confuse us all the more. But essentially, there's a clinical classification, there's a pathological classification, and then there's kind of an infectious diseases process classification. So from a clinical perspective or an anatomical perspective, we tend to talk anterior, intermediate, or posterior, or pan-uveitis. Anterior uveitis, as you imagine, affects the iris and the anterior chamber. Okay, so it's anterior to the eye, anterior to the lens usually is the division anatomically. Intermediate is a bit of a kind of mystery, but it tends to be kind of the actual division of roughly around the ciliary bodies and the lens and a bit of the vitreous, okay? It's almost like the middle segment of the eye, but there's no kind of really good landmarks. Some people talk about the pars plana, okay, which is part of the retina that connects up to the anterior part of the eye, to the lens, the posterior part of the lens, and a division of a bit 1/3 into the vitreous. That is termed intermediate uveitis. And then we have posterior uveitis, which is just the neurosensory retina, okay, and the optic nerve. So anything that affects the neurosensory retina, as well as the choroid underneath, and the nerve is known as posterior uveitis. And Panuveitis is just all three altogether. It's just a very inflamed eye from start to finish, okay, from front to back. Clinicians like to define uveitis in terms of chronicity and timeline. So acute is very common. Acute uveitis is very common. In fact, I think there's a definition out there that says we're allowed to have one episode of anterior uveitis in a year before we start to get any investigations looked at. Unless it's, of course, if it's a simple anterior uveitis, we're allowed one episode before we start to look into why it's happening regularly. Chronic uveitis is multiple episodes, okay, within 3 months. And recurrent uveitis stems from chronic, and it's essentially multiple episodes, but over a longer period of time, okay? So chronic, a couple episodes within a 3-month period, and then that will eventually evolve into recurrent uveitis if we still haven't fixed the problem, and that spans over greater than 3 months. And then pathologists or, infectious disease specialists like to refer to uveitis as either granulomatous, okay, depending on the type of cells they might see under histopathology, or non-granulomatous, the cells that tend to not be kind of granulomatous in nature. We'll talk about the different types of cells that we see in uveitis later on, okay? So those are the kind of different classifications. For the intent of this talk, for the purpose of this talk, we'll do the anterior, intermediate, and posterior, the anatomical classification. But don't forget about the other two because they kind of interlink. So uveitis, again, for me, I never understood fully at the medical school level what uveitis was. I knew it was a differential for a red eye, and I knew it had some form of immune response. That's as far as I knew. Also, a few systemic symptoms seem to crop up every time someone has a uveitis flare. So the etiology or the cause of uveitis, well, most of it we don't know, unfortunately. It's idiopathic. And this is the term that we use, once again, to confuse our patients when we don't know something but want to seem smart, okay? Idiopathic just means we don't know why it happens. And about probably 50% of cases of uveitis are idiopathic in nature. But the other 50% have some form of immune, autoimmune, or infectious etiology. So in developed nations, okay, places that hopefully a few of us are residing in right now, I don't know, hopefully. In developed nations, most uveitis is autoimmune related or due to a dysregulated immune response. And we'll talk about the difference between the two because there is a subtle difference. And as a result, we have a lot of conditions that we need to know about that cause these autoimmune or dysregulated immune responses, okay, to cause us to have uveitis in the developing world. This is stuff like HLA-B27 arthropathies, also known as seronegative arthropathies, okay? Seronegative meaning they're rheumatoid factor negative, and that's what rheumatologists like to refer them as, okay? HLA just meaning a specific type of cell surface antigen that is unique to all these conditions, okay? So hopefully this isn't too much of a confusing term, but it's a group of conditions that are unified by a specific cell surface antigen that rheumatologists are the specialists at, okay, at detecting with all their various blood tests. Sarcoidosis, okay, Behçet's disease, multiple sclerosis, and juvenile idiopathic arthritis. There are a few other forms of uveitis and causes that we should know about, but the main ones are up here, okay? The big yield ones are up here. I think these are slightly more minutiae and less frequently seen, okay? For example, heterochromic cyclitis would be one of those conditions that your consultant might invite you to watch or see because you might not see it for another, year or two, okay? So these are rare conditions. In less developed nations, okay, so places that you might potentially visit on your elective, if you decide to do an ophthalmology elective, places like cataract camps, okay, the etiology tends to be infectious in nature. I don't know why, but a lot of places, for example, at least in cataract camps, for example, in kind of more developing nations, they don't have good antibiotic prophylaxis, okay? So they'll do a cataract, a quick operation, and they're very good at it, but they won't provide antibiotic prophylaxis. And so these patients catch endophthalmitis, and then their immune systems end up thinking that the bacterium that is self-antigen, for example, they'll start attacking self or cells that are their own, okay? So that's one mechanism, for example, of uveitis from an infectious nature. what tends to happen with all these conditions, tuberculosis, syphilis, Lyme's disease, and herpes, is the immune system gets confused that what it technically is fighting, it thinks it's fighting a virus or a bacterium or some form of acanthamoeba, for example, or some form of fungus, but in reality, it's killing off its own self, okay? And I'll talk about that a bit later. Main thing, developed nation is autoimmune, developed nations, autoimmune, developing nations, infectious, okay? And these are the common causes. So just super quickly, okay, let's just talk about what's the difference between a dysregulated immune response and an autoimmune response, okay? A dysregulated immune response is one that was meant to be local, a local inflammatory response, but then becomes systemic, okay? And this can happen anywhere. So you've got, for example, ignore all the inner text. This was from an essay a while ago that I did, but ignore all the inner texts and you have a pathogen, okay? Or you have some products of a pathogen after a damage response from our, for example, innate immune system, okay? This is recognized by an antigen presenting cell and it tries to contain the infection by it's signaling more neutrophils and more macrophages to come to that site and to keep the infection local and wall it off, okay? Or form some form of granuloma or kind of a local inflammatory response. And this involves a lot of cytokines, okay? And as a response, it keeps the infection at bay, but tells the immune system there's an infection going on. A dysregulated immune response, a bit like a systemic inflammatory response, is when that local infection, the whole body hears about it and the whole body reacts towards it. And so when these toxic cytokines are released into our kind of bloodstream to other organs that start to recognize this as a danger signal, then there's a whole array of things that happen that we don't want happening in other organs. So our blood tends to clot a bit more. Our immune system, because it's trying to shift into an anti-inflammatory state to depress the dysregulated response, depresses our adaptive immune system. There's endocrine dysfunction, cortisol gets released, and there's remote organ injury as a result of all this. Okay, whereas an autoimmune response is a bit different to dysregulated response. An autoimmune response is when our adaptive immune system, okay, recognizes our own cells as enemies, okay? So this is an antigen presenting cell, okay, like a dendritic cell that chomps up bacterium and that tells the adaptive immune system, hi, this is a bacterium or a virus, can you kill it off, please? That's how it tends to work. In an autoimmune process, unfortunately, this cell will sometimes have cell molecules on its surface that are inappropriately recognized by some CD8 cells, B cells, and they mount an immune response to that. And typically how this happens is we have usually a viral infection or a bacterial infection early on in our lives as children. And then there is this process called molecular mimicry. And the immune system, because its memory is a bit hazy from back in childhood of this bacterial virus that it fended off prehistorically, it then starts to forget that memory and it attacks similar looking like peptides on the surfaces of cells. And these cells can sometimes be carrying similar peptides that are our own cells. Okay, so that's molecular mimicry. This is an autoimmune process. This is a dysregulated immune response, okay? Both are implicated in uveitis. I'm not going to try and bore you about the immune response. I think I've gone over the top of this, but every cell in uveitis is implicated. We have our acute cells and we have our kind of degranulation cells as well as our antigen presenting cells, the ones that are designed to trigger the adaptive immune response, okay? And in an adaptive immune system, in a uveitis picture, we tend to have a mix of both Th1 and Th2 responses depending on the type of etiology. So infectious uveitis tends to produce a more Th2 response, whereas autoimmune tends to produce a Th1 response, for example. And these are the kind of cells that you might see in the pus samples if you were ever to sample a uveitic eye, okay? And so these adaptive immune cells, as well as innate immune cells, are inappropriately acting in uveitis to produce a non-focal infection or immune response, as well as sometimes they might confuse pathogen in infectious etiology for self. And so they will attack subsequently healthy tissue that is our own and that is host, okay, rather than a pathogen. So hopefully that makes a bit of sense. And various molecules are implicated, and this is all part of hopefully the immune response that we all learned about in kind of our early few years of med school. But chemokines to kind of attract cells to the area that need to be attracted, like macrophages, pro-inflammatory cytokines like interleukin-1, TNF-alpha, interferon gamma, adhesion molecules, and immune antibodies all play a role in uveitis. And one thing I want you to take away from this slide is the fact that the eye is immune privileged. And by that, it means the fact that the eye tends to try and keep inflammation at bay. Because if you imagine, if you were to inject a foreign antigen into the anterior chamber, and the eye was to mount a full-blown response to that foreign antigen, this place becomes very murky suddenly because it's flooded with cells trying to help the response. The eye is immune privileged, and it helps delay that response through a combination of suppressor cells from the adaptive immune system, as well as T regulatory cells from the adaptive immune system again. So it keeps inflammation at a minimal in the eye. It almost buys the eye 12 to 24 hours for it to fix the problem locally with the innate immune system, you know, the local macrophages, the local dendritic cells, and the local antigen presenting cells to eat up the pathogen before it's a dysregulated immune response. In uveitis, unfortunately, that system goes wrong. And immune privilege is driven by this process called regulation, the eye-driven systemic regulatory process, or the ACAID system, okay? There are other systems that help maintain immune privilege in the eye. And we've previously talked about the blood-retinal barrier, okay? It's very leak-proof to certain types of antibodies and certain parts that might be going around the wider kind of body. And there are T regulatory cells, okay? These police cells to help regulate an immune response. We'll talk about this in a bit. So uveitis, it's an autoimmune process. And as we know from, once again, a bit of physiology and anatomy, the thymus does a lot of culling of T cells that respond in an inappropriate manner. So if there's a T cell that's maturing in the thymus and it recognizes a self-antigen, the thymus will kill it off, okay? So the thymus does something called central tolerance to help produce T cells that are appropriate and can attack, when needed, foreign pathogens and not our own cells. There is peripheral tolerance, okay, known by usually T regulatory cells, okay, these new forms of T cells that help maintain a good order, a good standing order between these killer cells and these cells that help produce antibodies with B cells, okay? These T regulatory cells known as peripheral tolerance. And then in the eye, we don't know too much yet, sadly, but there is this form of there's this theory called ignorance. Unfortunately, the lymphocytes or the T and B cells that sometimes reside in the eye, they're just sometimes a bit more naive compared to other mature CD4 and CD8 cells. And so they don't recognize infection as well compared to other cells in our body, okay? So this form of ignorance. And all this is done, hopefully by the body, to keep our kind of lens and our cornea, as well as our vitreous, you know, the window into our vision, clear and not mucky, okay? That is the main aim of this kind of autoimmune regulation, to keep vision preserved. And what goes wrong in uveitis, unfortunately, is we have certain molecules that are recognized as pathogenic. So these are known as the HLA molecules, okay? Human leukocyte antigens. And there are certain classic ones that are classic culprits, okay, for uveitis that are linked to certain diseases. So these molecules, unfortunately, are recognized as pathogens, and so the immune system attacks them and causes a uveitic picture. Infection, I've got ditto here, if any of you have played Pokemon, but essentially some pathogens have similar looking like peptides on their cell surface. And so when the immune system meets a self cell or like a human cell, like our own cells, and it meets a pathogen with similar molecules, it'll treat both the same. So if the wrong molecule is presented to the adaptive immune system, say for example, at an early age when we're exposed to everything from viral colds to bacterial infections in our children, that mimicry can occur, and the immune system then recognizes our own our own cells as the enemies. Sometimes there is trauma. So in trauma, for example, traumatic cataract forms, or if there's iris prolapse, sometimes there's shedding of antigens as a result of that. But in trauma, there's also necrotic tissue. So this shedding of antigens in the traumatic process, say that if the iris releases a few proteins, as well as the lens releasing a few proteins, and then it gets mixed up with these necrotic cells that are getting eaten away by macrophages that are local, the macrophages might mount an immune response to these released antigens from the iris or from the lens. And so that also leads to a uveitic picture sometimes. And finally, because local infection can't be sometimes kept local due to this immune privilege thing, there's a breakdown in the blood-ocular barrier, and there is leakiness, and there's exposure to the outside immune system. So a focal infection no longer stays focal, unfortunately. So this is what tends to go wrong in uveitis, and this explains a lot of the signs that we see in uveitis. Okay, hopefully none of you mind me explaining that a bit more. It just hopefully puts a bit of context as to why we see the stuff we see in uveitis, and I'll talk about all the signs in a second. Okay. Hopefully no one has any questions. No questions so far. Okay. If you have any worries or anything, raise them now. But this is essentially why uveitis goes wrong, or why the eye becomes this autoimmune immune inflammatory response, okay, which manifests as uveitis, okay. And this is the HLA molecules that I was talking about that sometimes have specific links with types of uveitis syndromes, okay. Once again, HLA stands for human leukocyte antigen, and this is just a way of identifying cells that are unique to us, as well as sometimes pathogens, okay? So each cell, depending on its function, will have a unique HLA set on its cell surface. For some reason, these conditions like birdshot chorioretinopathy, in Behçet's disease, in anterior uveitis, I want you to particularly pay attention to HLA-B27. This is a very important one for anterior uveitis. And Behçet's HLA-B51 is quite a common question. And then other conditions, okay? These, for some reason, get recognized inappropriately and have a high correlation between a uveitic syndrome and high expression on cells, okay? So the immune system's reacting to these guys. So our next step is to understand anterior uveitis as a cause of a red eye, as well as the classical signs we might see in uveitic syndromes, okay? So uveitis, when a patient comes into your clinic, okay, you're a senior ophthalmologist or a junior ophthalmologist, and the patient comes into clinic, they'll classically complain of three main things that makes you suspect a uveitic syndrome, okay, before even asking a systemic history. It is pain, photophobia, and blurring of vision. That is the classic triad. The injections, or the red eye supposedly, okay, patients don't tend to see too much because it's quite a perilimbal injections, okay? Perilimbal meaning this is the limbus, okay? This is where the cornea starts on this side, and this is where the conjunctiva lines. The limbus is where the two meet, okay? So at the limbus, there are some fine injections, and unless you've got a very astute eye, which you don't because you've got uveitis, you won't see the red eye form. So usually people don't complain of a red eye at the first instance. They usually complain of pain. My God, is it painful? Oh my gosh, I can't stand light. They might come in with black glasses into your clinic, okay, saying I can't stand light, and they'll have blurry vision. That's the classic triad of uveitis, okay? Less classic things are stuff like an irregular pupil, headache, watery eye, and floaters, okay? Those are less classic things. Irregular eye because the pupil's very stuck down because adhesion molecules as part of the inflammatory response have been upregulated. Headache because there's referred pain from the eye. Watery eye because once again, you've got a painful eye, and so naturally your lacrimation reflex in response to pain will kickstart. And floaters because you've got a shit ton of debris, both innate and adaptive cells in the eye. Some other signs that you can see, stuff that you then start to examine in the patient as a junior ophthalmologist or a senior ophthalmologist, you start to see injections, okay? You notice this pattern of injections. They're very perilimbal, okay? And they're not your diffuse superficial injections that you might see, for example, in scleritis. You see a hazy stroma, okay? So there's a bit of haziness. So the cornea is a bit upset, okay? It's not quite functioning as well as it should be. You see a hypopion, okay? A collection of dead cells, okay? Usually from an inflammatory response, okay? The warriors who have passed the battle, okay? These are like your neutrophils and your macrophages who have passed the battle, all the dead bacteria or infectious stuff that you fought off. And synechiae, another fancy term that we use in medicine to confuse people, but it effectively means sticky iris. So your iris, in response to inflammation, has increased these things called adhesion molecules. And that's all a normal inflammatory response. Adhesion molecules help vascular cells attract macrophages to the site of inflammation. So when mast cells degranulate and say, hello, let's make more vessels kind of wider, vasodilated, and more blood come to this area, adhesion molecules get expressed on the vascular endothelium, and we get these kind of adhesions seen in the iris, okay? And they stick to the anterior capsule of the lens, which is just behind the iris, okay? The lens itself has a membrane around it, effectively, a clear membrane, and it sticks to those elements of that membrane. And that's called synechiae. So, some classical signs that you need to know for uveitis, okay? Sadly, not a technical term. Shit ton is not a technical term, everyone. Use sparingly. But some classical signs that you might see for uveitis, okay? So, chorotic precipitates. This is the upper picture, okay? So when you look at this eye, before you see a hypopion form, okay, you might see chorotic precipitates, small little blotches of usually white and regular kind of sized dots that will be effectively immune cells clumped together that are trying to produce an inflammatory response or have come to produce an inflammatory response. They tend to be polymorphic nuclear cells, meaning the neutrophils effectively that have come as the first warriors to the fight, okay? But then as they age, they tend to kind of become more irregular and pigmented. And with time, if it's a recurrent uveitis, okay, recurrent meaning more than a couple episodes for longer than 3 months, you might get mutton fat precipitates if it's a recurrent or chronic uveitis. And that's effectively like chorotic precipitates, but effectively different types of cells, once again, clumping together at a place where gravity does most of its actions, which is the lower part of the cornea. Okay, this is the mutton fat precipitates. They look greasy in nature, they're yellowy, and that's why they're named after mutton fat, okay? These tend to be macrophage, and they also tend to be associated with granulomatous infection, which we'll cover in a sec, okay? Different type of inflammatory response in response to the type of antigen they're fighting, whether it's infectious. And why? Okay, so chorotic precipitates we talked about, they deposit on the cornea, and mutton fat also deposit on the cornea and tend to be associated with granulomatous infections, only because we tend to need different cells to attack stuff like sarcoid or TB or syphilis, that a different cell type is used to produce an inflammatory response with these conditions. Okay, so that's why we get mutton fat stereotypically with these. Other classical signs you might see are cell and flare, okay? This is a very difficult sign to elicit on a slit lamp, but essentially you use a fine narrow beam, slightly dim, and you pop it to 30 degrees, okay? So you look from an angle. So here, you see the lens, you see the cornea, okay? And it's all its layers. So you'll see like the epithelium and a bit of the endothelium and the stroma of the cornea, and you're looking at the anterior chamber. So that's why you need a thin slit lamp, okay? A thin slit on the lamp, as well as a side view. And in the side view, you'll see all these dotted cells. This is what usually forms the anterior, or sorry, the chorotic precipitates. These cells are swimming around in the anterior chamber, and then they'll clump around the cornea, okay, to form your chorotic precipitates and mutton fat. So any cells and flare are found in the anterior chamber. And once again, they're part of the acute inflammatory response. And they're graded, okay? There's a grading system, which you need to probably be more aware of than know. But the more cells you have, I think you usually divide it by 10, roughly. So if you have 20 cells and divide it by 10, you have 2 grade. If you have, for example, 30 cells and you divide by 10, you have a 3 grade. It's not a hard or fast rule, but it's roughly, okay? Classical signs, synechiae. So you get two different types of synechiae, and they tend to cause the photophobia because the iris is not able to regulate its aperture. So basically, if you have a big light that's shone through sometimes a very undilated iris, okay, that will aggravate the neurosensory retina, okay? So that's why you tend to get photophobia, because the iris isn't regulating its aperture, it's stuck down. These down here are known as posterior synechiae. There's the iris, okay, there's the iris, and they're adhering through an increase in adhesion molecules to the anterior capsule of the lens, okay? Peripheral anterior synechiae are kind of what they say on the tin. They're best visualized with a gonioscope, okay? A gonioscope is like a different type of lens that you pop on the eye and you can see the angle of the eye much better. So effectively, if you look at this eye, you've popped on a very special lens onto this eye using your slit lamp, and you can see the angle, which is usually located around the limbus area here. So this is a side view of the angle up here, okay? Here's your lens, here's your iris, okay? And here's your iris, here's your aperture or pupil, okay? And down here should be a very nice trabecular meshwork or your angle of the eye. But instead you've got these synechiae, these sticky parts of the iris that are sticking down to the lens, down to the angle, okay? So these are peripheral and they're anterior synechiae. And because of this process, you can sometimes get what we call uveitic glaucoma, because these synechiae block the drainage angle. And by blocking the drainage angle, we get glaucoma as a result of an inflammatory process. So that's how that occurs. So we've talked about the integrins and adhesion molecules, and that's why synechiae occur. Once again, this is all part of a normal inflammatory response, but the eye in uveitis, through usually a genetic predisposition, doesn't adhere to the ocular privilege or the immune privilege that the eye has. It dysregulates the immune response and it makes it inappropriate. Other signs that you might see are iris nodules. Once again, every sign in uveitis is due to cells from the acute inflammatory response clumping together and forming kind of clumps. So this is just like that. These are clumps on the iris, but instead we've got confusing eponymous names for them. We've got Koppe nodules, okay? Koppe nodules are, let me remember which ones are they. I think they're the ones that sit just on the edge of the iris. So these are Koppe nodules. And then we have Basaka nodules, okay, which sit around the iris or in every other type of iris, and they look like craters more than anything. They'll create sometimes craters or they'll create kind of little mounts, okay? So you've got Koppe nodules that are specifically just around the aperture of the iris. And then you have Basaka nodules, which are around the whole iris, okay, as craters or kind of bumps. Why? Once again, you've got leukocytes, adaptive immune system, clumping together to form these craters. And specifically with Basaka nodules, you need to note that this is pathognomonic for a granulomatous condition, for example, TB or sarcoid. So if you see these, once again, then you have to think granulomatous uveitis as a cause, okay? How do you manage uveitis? Well, it is a systems history. You need a very, very thorough systems history, okay? These people usually come with systemic problems before they have an eye problem, okay? And when we do a systems history, it's a bit like a rheumatology history. You talk about breathing, okay, for sarcoid and TB. You talk about skin lesions. So sometimes internal organs will produce peripheral stigmata, okay, of skin lesions. For example, erythema multiforme, erythema nodosum, you know, all these kind of skin lesions. Joint pain. So you might think about arthralgia, okay, rheumatic conditions. We'll talk about the seronegative arthropathies. Dysphagia, if you're thinking about Crest syndrome for a vasculitis cause. Bleeds from your kind of mouth or your anus, okay? So these might be IBD. Genital ulceration, if you're thinking about syphilis as a cause. Dysuria, if you're thinking about an inflammatory response due to an STI. Recent travel is important. TB-ridden areas, okay, if you're not vaccinated. Then you might think about ruling out all the other various causes, okay? So it's a very systemic approach, okay? You're not focused on the eye. You might do a MON2 test for rule out TB, see if there's immunity. You will do some simple bloods to see if there's an inflammatory response. And a lot of these conditions, uveitis, will have a raised ESR and CRP, as well as sometimes some form of kidney injury because they're usually more systemic, and obviously some form of white cell derangement in their full blood count. In sarcoid, I think you tend to get a raised calcium. I might be wrong with that. Then you do a vasculitis screen, P-ANCA, C-ANCA, and ANA, just to rule out any other causes of your uveitis that might be autoimmune related, okay? A lot of vasculitic conditions are autoimmune related. And then you do some special tests, for example, Lyme serology, syphilis serology, and sarcoid enzyme assays, okay? Blood cultures to rule out infectious causes that are obvious, chest x-ray to look for TB sarcoid. Then you might start to think about some weird and wonderful tests. The mainstay of management with uveitis, gosh, it is a very complicated condition, but it's very simple to manage if it's just an acute flare that's a one-off, okay? If it's an acute flare that's a one-off, you want to reduce the pain for the patient. So you might give them cyclopentolate or atropine to help alleviate the pressure on the iris, okay, and to reduce the adhesions, okay? So cycloplegics is what we call those, to help the iris do its job and not be spasmy. And then we give anti-inflammatories, topical anti-inflammatories to dampen down the immune response. The eye in uveitis is no longer adhering to immune privilege, okay? It's no longer trying to delay the immune response. It's created a mess. It's created loads of cells. It's invited a party of immune responses. So we use our own steroids iatrogenically to reduce the inflammation, okay? So anti-inflammatories like topical steroids to help clear up the vision, as well as to target the inflammatory response. And as we talked about, sometimes people get glaucoma as a result of the synechiae clogging up the angle. So we might want to do glaucoma medications. If we've wonderfully allocated an infectious cause, because we're in a cataract camp somewhere in the middle of rural India, for example, then we'll do some antimicrobials, okay? And in some cases, the glaucoma is so bad that we need to do an iridotomy, or the synechiae are so bad that we might need to laser them off. And so then we have pieces of iris effectively on the anterior capsule of the eye, okay? And then obviously with our topical steroids, to avoid any rebound immune response, we want to taper the steroid dose gradually. And usually you reduce it, every hospital has different trust policies. But usually with ophthalmology, if you've got topical steroids, you reduce from say a 1 hourly prescription to a 2 hourly prescription, then to a 4 hourly prescription, et cetera, et cetera, et cetera, okay? In very bad cases of uveitis, i.e. recurrent or chronic, we might employ the same drugs that we use in rheumatology, which are immunosuppressants or immune modulating drugs. These are very toxic drugs. They carry loads of side effects, so we do not use them lightly. So as I said, if you've got an acute flare of uveitis, the mainstay of treatment is this, and then we refer to tertiary care to consider other stuff, all right? Hopefully this is still making sense. Intermediate uveitis, okay? Would we expect to know doses regimes for these drugs? I wouldn't say so, no. It's very unfair to ask stuff like that. And plus it varies between hospital policies. There's no unified way of weaning someone off steroids. Everyone will do it differently. And there's no kind of particular first choice anti-toxic agent or anti-immunosuppressant agent you'd use. So I wouldn't, just be aware of them. So uveitis. Intermediate. This is a bit of an oddball of uveitis, but when we're going back to the classification of uveitis, we think about anterior, intermediate, and posterior. And once again, they don't tend to occur on their own, but intermediate is this kind of very gray area between the pars plana, okay? This is where the neurosensory layer of the eye stops just before it hits the posterior capsule of the lens, okay? Hopefully you guys can see my pointer. The pars plana, I repeat, is the most anterior part of the vitreous or the neurosensory layer before it stops at the posterior capsule of the lens, okay, roughly there. So at this area and about 1/3 into the vitreous, we have the kind of intermediate range or the middle part of the eye, or the kind of, if we were to cut the eye open, this is where the middle part is. And this is where intermediate uveitis affects. The etiology is still similar to anterior uveitis, okay? We have mostly infectious as well as autoimmune processes, okay? And it tends to occur bilaterally in young people, okay? We have a few eponymous signs that we tend to think about intermediate uveitis. So if the question starts to say, for example, there is snow banking, okay, so snow banking is effectively kind of white clumps of inflammation, effectively, in the kind of peripheral part of the retina, usually the pars plana. This is not your stereotypical fundus that you see here, actually, okay, as you can imagine. This is an expanded fundus imaging. And so this usually needs an extra machine for them to visualize it, but it really helps us visualize the peripheral retina, which sometimes we might miss with an indirect or with a Volk lens, okay? So when we image the whole retina, we sometimes see in the peripheral sites this snow banking appearance, okay? And snowballs, you know, another funny term that we use, is just isolate clumps of cells, effectively. So usually not around the peripheral retina. This isn't probably the best image. It was the best one that I can get for free, though. So snowballs are more central, and snow banking occurs more peripherally. And then this one, no kind of, you know, no awards for this, but this is basically a hazy vitreous. And this is what vitritis looks like. It's just full of debris. Various chemokines, various cells, all kind of smothered in. And so that's why we tend to get painless blurring of vision with new floaters in intermediate uveitis. Okay. And the workup is the exact same, unfortunately. You look for your system's history to see if you're looking for a focal infectious cause or an autoimmune cause. So for example, infectious causes could be granulomatous TB. So here's a cavitating granulomatous lesion in the apex of the lungs, okay? And it will just reside there, causing the occasional outburst of inflammatory response, which in a non-immune privileged eye, because it's got uveitic syndromes, it will start to react and form uveitis. So maybe a reactivation of TB might initially come across with a uveitic picture, okay? And then we've got a non-infectious cause, but still granulomatous, because the cells that tend to get involved are more of a granulomatous picture. These are like your macrophages, your foam cells. Foam cells are big macrophages that have been eaten up by each other effectively. It's just the cell type that dictates whether it's granulomatous or not. These are nerdy pathologists who sit down with their microscopes and count the cells effectively. So these are two granulomatous conditions. One's infectious, one's non-infectious. And in sarcoid, we tend to have, if it's very severe enough, we have respiratory problems. We sometimes have multi-organ problems, but typically we see bilateral hilar lymphadenopathy. So the hilar here are very bulky. So that should scream either lymphoma or sarcoid, okay? So that would be your differential, for example, for bulky hilar. So you would go for a systems approach again with intermediate uveitis. And once again, the treatment's the same. Steroids suppress the immune response, okay? I'm not sure what I meant by CMO, unfortunately, but oh, cystoid macular edema. So in a lot of uveitis, because cells are releasing chemokines and there's an immune response, we sometimes get a buildup of pathological kind of macular edema, okay, under the retina, which leads to distortion and warping of someone's vision. But that's a complication that's stereotypically seen. And if we employ systemic immunosuppressants, sometimes they do the exact opposite of keeping the infection at bay, and they actually help proliferate the infection by damping down our immune system. So sometimes cystoid macular edema can be seen as a complication as of a primary infection and when we intervene, okay? Posterior uveitis, okay, affects the choroid or the retina or the vessels, okay? Remember, we are talking about a vascular tunic, okay? The middle layer of the eye is a vascular tunic. So here we either have choroiditis, for example, a choroid inflammation, or we have the vessels of the choroid inflamed, a choroidal vasculitis, okay? Once again, fancy terms that mean the exact same thing. We have the back of the eye that is inflamed, and the back of the eye, we tend to find the retina as well as the choroid. So symptoms, we get, once again, painless blurring of vision with new floaters. But because we're affecting the neurosensory retina this time around, we will have what we call photopsia, okay? Photopsia meaning kind of these odd flashers, or sorry, these odd flashing lights or kind of images that aren't in keeping with what you're seeing in the real world because the retina is becoming upset. and dyschromatopsia, which means that the color vision is being affected, okay, and you're not seeing the regular colors. Management, well, find the cause and treat it. And the one thing I want you to take away from this slide, as you'll see in a sec, posterior uveitis tends to be more infectious causes, okay, and there's loads of them that you need to remember. CMV retinitis, okay, classically comes with a pizza pie appearance. You'll technically see in questions pizza pie appearance. Toxoplasmosis retinitis. I forgot how this is described, but it's almost like a light in a fog, I think. It's called a light in a fog because, as you can see, it's this very necrotic lesion, and then suddenly you've penetrated through to the lower parts of the eye that are more visible, okay? So this is called a light in a fog appearance, I think, almost like there's a light amongst the darkness, okay? Candida retinitis is usually kind of pearly beads. It's referred to as pearly beads. So unfortunately, all these infectious causes carry very specific descriptions that should point you towards that question when you're looking at it in a Duke Elder question, okay? So Candida, a fungal infection, tends to have pearly beads attached to it. So there's the pearly beads and this kind of focal discrete lesion. So there is actually a condition called PORN, okay, in response to herpes virus, okay, which is adequately responded, okay, adequately named. But PORN stands for peripheral outer retinal necrosis, I believe. So herpes, okay, or some form of herpetic infection, if it's in the retina, will cause these kind of, once again, discrete but kind of clumped together lesions, okay, that cause a slightly paler retina, okay, wherever the herpetic infection's gone. And it tends to be in an arcuate shape because that's how the nerves are distributed at the back of the retina, okay? So that made me laugh, but PORN, okay, peripheral outer retinal necrosis, I think. Cat scratch retinitis, okay, tends to affect the macula and it produces this kind of stellate appearance, okay? And sarcoidosis, the one non-infectious cause here, okay, remember that 2 of these are from torch infections for vertical transmission of mothers, okay, to children. So these might be present in your neonatal exam sometimes if the mother had been undetected. Sarcoidosis is usually seen as these punched out necrotic lesions, okay? So everything that's dark is necrotic. Everything that's lighter means that the choroid and the retina have thinned, okay? So that's what you're seeing there, punched out necrotic lesions in the peripheral retina specifically. Okay, so there's loads of these, unfortunately, but here are a few eponymous / classically described ones, okay? In summary, there are loads of causes for uveitis. I wouldn't stress too much, but do learn so pick a condition and learn the very specific signs that come with that condition that let ophthalmologists put them in exams to test students. That's the best way to describe it. Because if you officially go to an ophthalmologist, none of them will know all these causes off the top of their head. Uveitis and ocular immunology is a very complex topic that is very specialist, okay, and handled in very specialist centers. So we shouldn't know it off the top of our head either. We're going to blitz through this. I apologize for the delay, guys. I've spent too much on uveitis as always. So appreciate all the other systemic stuff that we can come in with the eye. This is the classical medical school stuff, okay? We'll talk about some of the seronegative spondyloarthropathies. What I mean by that, seronegative, meaning rheumatoid factor negative. Spondyloarthropathy is just a fancy term for joint problem, all right? And these are usually linked with uveitis because they have a specific human leukocyte antigen that causes a uveitic syndrome. So for example, in Behçet's disease, which we won't cover in this talk, sadly, HLA-B51 is affected. And in an anterior uveitis, there is a cluster of conditions that I want you to engrave in your head if you can, known as the seronegative spondyloarthropathies, because they are linked with HLA-B27. These are the 2 conditions I would know for the Duke Elder, okay? I haven't covered Behçet, sadly, in this talk, but the seronegative arthritis stuff is here. And these tend to present with, we can either have ankylosing spondylitis, there's a classic 4, okay? Ankylosing spondylitis, reactive arthritis, psoriatic arthritis, and IBD. Remember, ulcerative colitis and Crohn's disease can present in extraintestinal manifestations, okay? One of them is an arthropathy as well as uveitis. In Behçet's disease, it's a very different HLA molecule, but also classically tested on MCQ tests. And I put our heroes of the immune system here because once again, we need to remember that this is a dysregulated immune response as well as an autoimmune response, autoimmune process, okay? Ankylosing spondylitis, okay, classically affects young males, okay, technically in their 20s to 30s. They tend to initially see stiffness in the early mornings of awakening that's improved or relieved with regular exercise, okay? If they start to develop further without any right treatment, they start to get a thoracic kyphosis, such as this, okay? So they start to hunch over quite badly, and their lumbar lordosis, okay, tends to get lost, all right? Ankylosing spondylitis is classically remembered with the various A's. It's the disease of the A's. I don't know if that's the best way to remember it, but you've got anterior uveitis, which is quite common, apical fibrosis, aortic regurg, AVN heart block, arthritis, and Achilles tendonitis. Young males, worse back pain in the morning, gets better with exercise, and very strong HLA presence, okay, with B27. They tend to get non-granulomatous recurrent uveitis, which usually obeys the anterior segment, okay, in terms of anatomy. You would initially do an X-ray, simple blood to see if there's an autoimmune process going on or some form of rheumatological problem, and you would advise them accordingly, okay? Exercise, non-steroidals. Psoriatic arthritis, okay? We are talking about a dermatological problem here, psoriasis, shiny salmon pink scaly plaques, okay? That can also result in an arthropathy if severe enough. And in this process of arthropathy, okay, this is usually linked because there is a HLA B27 link, okay? And these individuals tend to present with chronic uveitis as a result of it, okay? In addition, to confirm your diagnosis, if you're thinking of a psoriatic arthropathy, you will have nail changes. So there's pitting, okay, of the nails. There is also these chubbiness of fingers, okay, known as sausage fingers or dactylitis, or dactylitis, I think is the right term for these sausage fingers. And in rare conditions, they'll be so mutilated that they're beyond even recognizable. And this is known as arthritis mutilans. And it's usually mostly associated with HLA B27. So there's a very bad immune response leading to very degenerative arthropathy. Okay, non-steroidals and disease-modifying agents are our way of managing this. Then we have reactive arthritis. I put up our lovely Pokemon Ditto here because this tends to occur because of molecular mimicry. Okay, you usually have an infection in these patients that classically is either an STI. It can sometimes be a diarrhea infection or gastroenteritis infection like Campylobacter or Salmonella. These bacteria have similar proteins on their cell surface, and so our immune system recognizes them as that, and it attacks our normal self, okay? And this is known as reactive arthritis. It is reacting to the infection that you had about a week ago, okay? And there is a classic triad. Rita syndrome is a classic triad of can't see, can't pee, can't climb a tree. You can't pee because you've got urethritis, the common infection of an STI. Okay, so you've had a recent infection. You can't see because you have anterior uveitis or conjunctivitis. And you can't climb a tree because you have these skin lesions as well as an arthropathy that's developed. But it's a sterile arthropathy with a low-grade fever. So it's not a septic arthritis, but it would form part of your differential. Finally, inflammatory bowel disease, not much to say about this. The classic GI symptoms. All I want to say is there is a strong genetic predisposition with HLA-B27, and so they get a chronic form of uveitis. It tends to occur in Crohn's disease compared to ulcerative colitis, okay? And once again, we need to know the difference between Crohn's disease and UC because they're slightly different, but that's more of a gen med question. I'm throwing in juvenile idiopathic arthritis because it's associated with anterior uveitis, and we need to recognize it because it's the most common childhood arthritis that leads to anterior uveitis. In particular, the type of juvenile idiopathic arthritis that's associated with anterior uveitis tends to do worse off. So it's almost negligent on our behalf if we don't spot it, okay? So a lot of clinics will sometimes run in conjunction with ophthalmologists and rheumatologists, okay? Because of the fact that we have a lot of GIA cases that are shared with eye symptoms as well as joint symptoms, okay? but this is not HLA associated. This has different other antibodies that rheumatologists care about, not ophthalmologists, okay? GIA, most common form of anterior uveitis or cause for uveitis in kids. Blitz through again, thyroid eye disease, okay? Super quick. Graves' disease is the one that produces exophthalmos, okay? This bulging eye look, okay, with proptosis going forward. Graves' disease is the most common cause. It's a hyperthyroid condition, okay, primarily. Technically, we usually see more white sclera showing, okay? There's lid retraction. If you were to ask them to look down, there'd also be lid lag because it's stuck. There is painful eye movements as well as diplopia, double vision, because the eyelids are the eyes are so far forward, okay? We need to check in terms of our TFTs to make sure nothing, we're moderating the thyroid well. And some of the main emergencies with thyroid eye disease, as you can imagine, if you can't shut your eyelids, you get this thing called, you get problems with your cornea effectively, and it's called an exposure keratopathy. Exposure because you're drying out the cornea, okay? Exposing it to the natural air. And keratopathy just means a fancy term for cornea degenerating. If you leave this for long enough, this is a exposure keratopathy with a bit of staining, okay? This is where the cornea is losing epithelium. If you leave this long enough, you'll get a corneal erosion, which is susceptible to infection. And you will eventually get corneal melt if you leave it really long enough, okay? Which means the cornea is falling apart and leaking content. Also, because there is antibodies against the muscles behind the eye, you get optic nerve compression. You get a bit of a compartment syndrome behind the eye if you leave it long enough, okay? You typically need to modulate the thyroid properly, okay? You can sometimes give lifestyle advice. In the acute phase, if you see this as an ophthalmologist, you want to give them lubricating eye drops, which you tell them to put in hourly, as well as an ointment at night. And you might even cause them to do you might refer them for a botulinum toxin if they can't get decompression surgery soon enough to help the eyelid drag down, okay? If there is an emergency, such as the ones I've mentioned, then you need to operate within 2 weeks, and you tend to decompress. You get rid of the lateral wall, and in some cases you can even do endoscopically, you can get rid of the medial wall. Diabetic retinopathy, once again, something that's drummed in at med school, hopefully. So I'm just recapping. You need to know how it's staged, but it's the main cause of blindness, unfortunately, in the Western society, second behind cataracts, okay, which is a reversible cause. So diabetic retinopathy is staged depending on the signs that you see. So you see these microaneurysms in certain quadrants, meaning that the blood vessels are rupturing due to, the sorbitol effect, okay? Everyone remembers in diabetes, there's a sorbitol effect, meaning the vessels weaken because there's, impaction of sugar in the vessels. So you get these microaneurysms that form. That's one of the early signs. And then if these aneurysms ruptures, you get hemorrhages, okay? Referred to as dot blot hemorrhages, okay? So if it's local, then it's a dot. If it's a hemorrhage that's kind of spewed across and traveled under the retina, then it's a blot, okay? You get hard exudates, which is the vessels leaking crap, and you've got cotton wool spots, which is the neurons leaking crap, okay? So hard exudates, vessels, soft exudates or soft cotton wool spots is the neurons leaking crap. You also get vessel beading and tortuosity, hard to tell on these signs, but here you can see some more. And you stage it from mild to moderate to severe. In this case, this final fundus, we actually see proliferative diabetic retinopathy, which is the most severe form. Thankfully for this patient, it's not affecting the macula. So you would rate it as M0, meaning no macula affected. There's no proliferation of the macula, but this person needs anti-VEGF injections because there's proliferative diabetic retinopathy in roughly the quadrant. So the macula will go soon if there's new vessels forming there. Okay, this is proliferative. This is probably staged as severe because it's affecting all 4 quadrants, okay? All 4 quadrants, you can see aneurysms and dot blot hemorrhages. If a particular quadrant is affected, then it's known as moderate. And if you only see one sign, then it's mild. Diabetic retinopathy we talked about. You need to screen these patients and you need to control their diabetes. If they have proliferative diabetic retinopathy, i.e. new vessels forming because of the ischemic attack on the retina, you want to refer them to an ophthalmologist ASAP within 2 weeks because you want them to do anti-VEGF injections. And anti-VEGF means an injection against the vascular endothelial growth factor, VEGF, okay? Meaning that the vessels stop growing and they shrink, okay, as a result of it. So that's the way we manage that. Hypertensive retinopathy sometimes looks similar to diabetic retinopathy. We can see hemorrhages, okay? Flame and blot hemorrhages, they're called. These tend to be a more late sign, unfortunately, in hypertensive retinopathy. And it's usually defined as a persistent blood pressure above 160 systolic, and I can't remember the diastolic, but that's how you usually develop hypertensive retinopathy. So you need to control blood pressure adequately within the ranges. I think the most recent guidelines have changed blood pressure control to want to be less than even 140, not 150, which it used to be previously, okay? And once again, you get a classification, okay? So if you see arterial narrowing, which is one of the earliest signs, okay, you see them thinning and you just see the vascular wall, or a bit of tortuosity, that's stage 1. AV nicking is a bit like when you've got arterial venous overlap, okay? I don't know why it occurs in hypertensive retinopathy, but you've got overlap. So sometimes you'll see a vein over a arterial, but probably because there's a high diastolic pressure. In stage 3, we have these signs, flame blot hemorrhages, as well as exudates. Once again, exudates is just crap leaking out of vessels. And stage 4, we start to see ICP symptoms, okay, intracranial symptoms, okay? So we might see the disc being blurred, and we might see more systemic symptoms in the patient. We don't want to get to stage 4, ideally. Unfortunately, one of the main complications of hypertensive retinopathy is your vessels burst, especially the venous system. So you get what we call central retinal vein occlusions, which is what we see here. And you can get branch retinal vein occlusions. So if it affects a particular quadrant, for example, this is the superior temporal artery or vein, okay? If it affects that quadrant, then it's known as a branch retinal vein occlusion. And this is what we call CRVO, BRVO, okay? Crevaux, Breveau. I don't know if that's the right way to say it, but that's a vein occlusion,